Good day, everyone. My name is Jack, a cardiologist from Singapore and the current president for the International Society of Cardiovascular Pharmacotherapy, as well as the president for the Asian Pacific Society of Cardiology. It gives me great pleasure and it's my great privilege to welcome everyone to the 26th ISCP Annual Scientific Meeting. Today's theme is keeping in beat with advances in cardiovascular pharmacotherapy. The ISCP is very proud to host this event in conjunction with the Asian Pacific Society of Cardiology, hosted by the Singapore Cardiac Society and EBAC accredited for CME points. I also give me great privilege to thank my co-chair, Professor Kenny Sin, as well as the president of the Singapore Cardiac Society, Dr. Ong Hian Yi, for their strong support for this meeting. I would also like to express my thanks to my two scientific chairs, Professor Doreen Tan, as well as Professor Mark Chan, for putting together this wonderful 2 days program. And thanks to my local scientific committee members. As you can see, all of them are involved deeply in putting together this exciting program for today. And a warm welcome to all the faculty members who have participated and are giving their lectures and moderating the session over these 2 days. And this series of faculty members are across the globe, truly echoing the international nature of the ISCP. A special thanks to Professor Barbara Cassidy, this year's 2021 Henry N. Newfield Memorial Lecturer, and we look forward to hearing her lecture soon. And we'd like to welcome all delegates and participants from across the globe in 70 countries to attend this 2 days program of ISCP. And I'd like to give special thanks to our industry partners, AstraZeneca, Novartis, Pfizer, and Vifor Pharma, and our proud media partner, MIMS. So let's get started. And the opening session for ISCP is Team Poised Take Over the World in Heart Failure Management. What is the landscape to come in 2021? So without further ado, let's move on to our first scientific session of the day. Thank you very much. And I hope we all learn together over the next 2 days.
Hello everyone, welcome to the first session of the ISCP 2021 Virtual Congress. So to kick off the session today, we will have the first session on Poised to Take Over the World in Heart Failure Management. So these are the faculty members which we will be introducing later on in the session before their speech. Just a few disclosures before the session starts. The content of this webinar is copyrighted by the ISCP and should not be distributed without the prior permission of the ISCP. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the ISCP. The session will also be live streamed via Wonder and ISCP, as well as an APSC Facebook and YouTube pages. The European Board for Accreditation in Cardiology grants CME points for attendees who attend the full session. You will receive your certificate of attendance upon completing a survey that we will send to you via email after the webinar. If you do have any questions during the webinar, please feel free to use the live Q&A box as seen on the screen to type in your questions. We'll try to answer your questions at the end of the session if time permits. If we do not answer your questions, we'll try and answer them via email. Alternatively, if you still have any burning questions after the session, please feel free to email your question to secretariat@iscp2021.com. So to kick off our first heart failure session, we will have with us Clinical Associate Prof David Sim, who is a senior consultant at the National Heart Centre in Singapore. He'll be presenting on the topic of IV iron, ironing out kinks in heart failure readmission, IV iron AFFIRMed. Prof David Sim, please.
Thank you for the kind invitation for this lecture on ironing out kinks in heart failure readmission, IV iron AFFIRMed. These are my disclosure. Please kindly take note that I'm the national coordinator for Singapore for the AFFIRMed HFrEF study. So let's start off with a case study on a 56-year-old Indian lady with dilated cardiomyopathy with an ejection fraction of 35%. She was admitted in 2018 for decompensated heart failure, and she was on ARNI, beta blocker, and an MRA, which is considered the gold standard for treatment of heart failure. Do take note, she's not an SGLT2 inhibitor because it was not approved way back in 2018 for heart failure. And the iron panel showed a decreased ferritin level, transferrin saturation, but she had a normal hemoglobin. So this kind of patient is quite common in our heart failure setting. The question we ask ourselves is an iron deficiency just a bystander? Is there a need to treat because she has no anemia? And if there's a need to treat, any role for iron therapy? And if we use iron, is it oral iron or intravenous iron? And what's the impact on the quality of life, readmission, and mortality? And lastly, what are the safety issue with the use of iron therapy? So first, let's talk about iron deficiency in heart failure. It is very common in heart failure. You can see in chronic heart failure, the prevalence ranges from 35% to slightly more than 50%. But in the setting of acute decompensated heart failure, the incidence increases much higher to as high as more than 80%. And iron deficiency is not just a bystander, it actually reduces the quality of life independent of the hemoglobin concentration for patients with heart failure. More importantly, it is also associated with an increase in the risk of hospitalization for heart failure. As you can see here, iron deficiency and not anemia is a predictor for hospitalization for heart failure. And similarly, it is a very strong prognostic factor for mortality than anemia in the setting of heart failure. So iron deficiency is a much stronger predictor than anemia for the prediction of survival. What about oral iron? Is it useful? It's something that's convenient that we don't need an intravenous therapy. But unfortunately, you can see from here that from the iron out heart failure study, there was a lack of efficacy of the oral iron. A high dose strategy of oral iron did not result in any improvement in the exercise capacity over 16 weeks. So this result does not support the use of oral iron in patients with heart failure reduced ejection fraction. And in terms of the intravenous iron on symptom and functional health in heart failure patients, we do have a few studies out there from FAIR-HF to CONFIRM-HF and lastly EFFECT-HF. But do take note, all this study was done in the ambulatory setting in chronic heart failure patient in the outpatient setting. And the trial were very small in the set, the largest trial only recruited 300 to 400 patients. And all the primary endpoint was a combination of 6-minute walk test or New York Heart Association class status. So not on heart clinical endpoint such as readmission or mortality. And the current guideline, whether it's from the ESC or from AHA, support the use of iron in the setting of chronic heart failure with a class 2 recommendation. And pulling all the results from this test that was done in ambulatory setting with FAIR-HF and CONFIRM-HF, you can see that there was a trend towards a reduction for cardiovascular mortality and hospitalization. But unfortunately, we have no randomized trial yet in the setting of acute heart failure. And we do know that in acute heart failure, this group of patients are at a high risk for readmission and mortality, what we call the vulnerable phase of the heart failure. So it makes sense to target this group of patients who are at a very high baseline risk. So the AFFIRMed HFpEF was studied to look at the role of intravenous iron in the setting of acute decompensated heart failure. And the patient were randomized in a 1-to-1 fashion to either intravenous ferric carboxy maltose or to placebo. And they were given the first dose of intravenous iron at discharge. And during the follow-up, they were allowed to have top-up doses of intravenous iron up to 24 weeks, and they will their outcome will measure all the way up to the 1-year mark, 52 weeks. And these are the primary and secondary outcome. You can see the primary outcome was a composite of total heart failure hospitalization and cardiovascular death up to 52 weeks. The key inclusion exclusion criteria, essentially heart failure patient hospital acute heart failure with iron deficiency defined as ferritin or less than 100 or between 100 and 300 with a T cell or less than 20% and a reduced ejection fraction of less than 50%. And patient with a hemoglobin range out of between 8 to 15 and active infection were not allowed to take part in the trial. This was a study treatment dosing regime. You can see that essentially it was either 500 or 1000 milligram of the intravenous iron based on the hemoglobin level and the weight of the patient to make it simpler for practical usage. More than 1000 patients was recruited in this trial with 550 roughly in both arms. As you can see here, majority of the patient, 80%, only required 1 to 2 doses of the intravenous iron throughout the duration of the study. These are the baseline characteristics, very typical for heart failure patient in the 70s, and majority of them were male patient, and ejection fraction was about 32%. Baseline medical therapy was a combination of RAS inhibitor, beta blocker, MRA. And these are the baseline lab data. You can see that the ferritin level was very low in both group patients in the treatment arm and the placebo arm of less than 100. And NT-proBNP was markedly raised in this group acute heart failure patient, more than 4,000. The primary endpoint was the total heart failure hospitalization and cardiovascular death. And you can see that there was a reduction in the event, and the p-value just narrowly statistical significant of 0.059. This was mainly driven by a reduction in the total heart failure hospitalization with a relative risk reduction of 26%. No difference was observed in the cardiovascular death at the end of 1 year. And if we factor in the impact of COVID-19 that happened during the conduction of the trial, the pre-COVID sensitivity analysis showed that if you factor in the impact of COVID-19, the p-value then becomes statistically significant, p equal to 0.024. Adverse event of interest, you can see here, there was no statistical significance between the treatment group and the placebo group. And at the end of the study, there was a higher level of ferritin level and the transferrin saturation in the group which received intravenous iron compared with the group that received placebo. And also the mean change in hemoglobin was higher in the group that had intravenous iron compared to the group that had placebo at the end of 1 year. So what are the implications for clinical practice? First, iron deficiency can be easily detected using a simple blood test. It should be accessed in patients hospitalized with acute heart failure. It's an important therapeutic agent target in patient heart failure. And from the AFFIRMed AHF trial, it's shown that administration of ferric carboxy maltose in patients with iron deficiency, ejection fraction of less than or equal to 50%, and who are stabilized after episode of acute heart failure, it reduces the risk of subsequent heart failure readmission. And that was what we did for this patient. She was enrolled in the AFFIRMed AH trial, and she was assigned to the arm that received the intravenous iron, and she is doing well since then with no recurrent readmission for heart failure. Currently, the result has been published in the Lancet, and you can actually refer to it for more details on the trial detail. Thank you very much for your attention.
Thank you very much, Prof David Sim, for giving us this insightful talk on IV iron. So next up, we have our second speaker, which is Prof Bambang Budi Siswanto, who is a professor in cardiovascular medicine in Indonesia. Today, Prof Siswanto will be presenting on the topic of ARNIs and HFpEF. Still alive? Prof Siswanto, please.
Good morning, ladies and gentlemen. The title of my presentation is ARNI and heart failure preserved ejection fraction still alive. This is my outline presentation. The death rates for patients hospitalized with heart failure across the world. You can see here that in Indonesia, we have 12% more in-hospital mortality. This is my paper during this COVID pandemic. The COVID-19 pandemic was associated with higher out-of-hospital mortality, including the number of out-of-hospital cardiac arrests. Effect of heart failure on the outcome of COVID-19. Cardiovascular disease, including heart failure, are risk factor for poor prognosis and double the risk of hospitalization and poor outcome. Meanwhile, have a threefold increased risk of mortality from COVID-19. This is my case for our discussion. She's a lady of 55 years old, and she had the risk factor, dyslipidemia, hypertension, and menopause. And this is the physical examination. And she had a chest X-ray and ECG last day. This is her chest X-ray. You can appreciate here. And this is her ECG for our next discussion. So what is your diagnosis? It's just a hypertension? So I will continue to my slides. The typical demographic of comorbidity associated with heart failure, persistent ejection infection is advanced age, hypertension, atrial fibrillation, female gender, kidney function, metabolic syndrome, obesity, physical deconditioning, pulmonary disease, and sleep apnea. You can appreciate here aging, hypertensive remodeling, sedentary lifestyle, poor obesity, and metabolic stress, and vascular stiffening is the risk factor. The data from Asian Heart Failure Registry, CAD, and hypertension and diabetes is the most prevalent risk factor. The prevalent risk factor is mostly in the Southeast Asian region. Multimorbidity of heart failure characteristic in Asia, there is 5 types: elderly with agent atrial fibrillation, metabolic, young, ischemic, and lean diabetic. The percentage of heart failure persistent ejection fraction in Asia, you can appreciate here, the country like Japan, Taiwan, and Hong Kong is most prevalent with heart failure persistent ejection fraction. And for the Southeast Asian heart failure, persistent ejection fraction have very poor survival. This is the algorithm how to diagnose heart failure with persistent ejection fraction. First is the initial workshop. You can test assessment like symptom and sign, comorbidity, ECG, echo, native peptide, and 6-minute walk test. E is for diagnostic workup, for example, for echocardiography. And F1 is advanced workup, functional testing for in the case of uncertainty. And F2 is etiological workup, like the MRI. This is the algorithm in patient with heart failure with breathless patient. You can appreciate here clinical assessment, standard diagnostic test, and pre-test suggestive of heart failure, persistent ejection fraction with multimorbidity. You can appreciate here on the right side the echo of heart failure with persistent ejection fraction with normal ejection fraction, but small left ventricle and enlarged atrium. The step 2 is to see the functional major and minor. For example, is the Doppler functional, the morphological, and also the biomarker in sinus rhythm or in atrial fibrillation. The step 3 is advanced workup of the echo stress test. You can do an echo stress test and then see the E per E prime, and then if it fulfills the criteria or not. For example, you can appreciate here the echocardiography during at rest and during exercise. We can see the functional parameter during exercise is different compared with the functional parameter at rest. On the step 3, you can work up for functional testing for in the case of uncertainty. We can use functional tests using an invasive test, hemodynamic at rest and exercise, where you can measure the pulmonary capillary pressure more than 25. Is it a heart failure preserved ejection fraction? The other algorithm come from Mayo Clinic. They use the H2F PEF score. You can appreciate here, they have a different score, more complicated. However, the therapy is successful for heart failure reduced ejection fraction have not demonstrated success in heart failure preserved ejection fraction. Recently, the sacubitril valsartan was used in the trial to see its usefulness in the heart failure with preserved ejection fraction. The paramount heart failure study design, the primary objective was to see is there any reduction of NT-proBNP from the baseline at 12 weeks. And the secondary objective is echocardiographic measurement of diastolic dysfunction and symptoms and quality of life and safety and tolerability. The result of Paramount showing the improvement of NT-proBNP, improvement in left atrial size, and improvement in New York Heart Plus. The other trial is Paragon Heart Failure Trial, recruiting 4,800 patients with symptomatic heart failure functional class 2 to 4 with ejection fraction more than 45%, LVH, left atrial enlargement, and elevated NT-proBNP comparison between sacubitril valsartan and valsartan. The primary endpoint result, the total heart failure hospitalization and cardiovascular death, the rate ratio 0.87 and the p-value 0.059. For hospital hospitalization and cardiovascular death, it showed the mostly benefit is come from prevention of heart failure hospitalization. On the subgroup analysis, the Paragon heart failure, it was shown that mostly benefit in women, also mostly benefit in patients with heart failure ejection fraction less than 57. Ladies and gentlemen, for summary, heart failure preserved ejection fraction is heterogeneous disease with multi-comorbidities. Diagnosis of heart failure preserved ejection fraction is most difficult and most important. The main general goal in heart failure preserved ejection fraction treatment is to alleviate symptoms and to control comorbidities. Despite showing some highlights on heart failure preserved ejection fraction management, need further study, especially in daily practice in each region, as in Asia. Paramount heart failure and Paragon heart failure showed the benefit of ARNI. Ladies and gentlemen, ARNI is still heart failure in preserved ejection fraction still alive. Thank you very much for your kind attention.
Thank you, Prof Suwanto, on the very comprehensive talk on HFpEF as well as the use of ARNI in HFpEF. At this kind point, I would just like to call for the audience who have any questions on the past two speakers and any questions on the topic to feel free to use the live Q&A box to type in your questions. So for our last and final speaker, we have Prof Felipe Martinez, who is the director at the Instituto DAMIC-Fundación Rusculleda, Córdoba in Argentina. He will be speaking on the topic of the use of SGLT2 in HFrEF, the new blockbuster. Prof Martinez, please.
I wish to thank the organizers for inviting me to this session in this important annual meeting of the International Society of Cardiovascular Pharmacotherapy. I am going to present my opinion about the use of SGLT2 inhibitors in heart failure with reduced ejection fraction. The new blockbuster. This is my coin, and my first part of the opinion is about the surprising start in this subject. As you know, two different programs, the HFrEF with empagliflozin and the CANVAS with canagliflozin, were presented and published about 4 or 5 years ago, demonstrated in diabetic populations a clear reduction of cardiovascular outcomes, and in particular, those related to heart failure. The second important point is the consolidation and expansion of this previous surprising start. A few years later, the first study in general population was presented with dapagliflozin versus placebo, and we published it in the New England Journal of Medicine 2 years ago and demonstrated a clear benefit of the patient receiving the study drug versus the placebo in the primary composite outcome and also in all the secondary endpoints. But the most important is that for the first time it was demonstrated that this benefit was similar in patients with and without diabetes. A couple of months later, we also published a sub-study demonstrating the relationship between the primary outcome according to age, and the result was similar in all groups of age, but the most important that it was even more significant in older patients where we do know that heart failure or the incidence of heart failure is higher. Almost 1 year later, the payroll reduced with empagliflozin demonstrated a similar result, and it was a consolidation of the results presented by DAPA-HF. And more recently, a couple of months ago, it was presented and published the soloist program with sotagliflozin and the SCORED protocol in diabetic patients demonstrated that the drug produces a reduction of the cardiovascular mortality and cardiovascular endpoints in all the ranges of ejection fraction, and in particular over or higher than 40%. And this is very important. And just a few days ago, a press release of the sponsor demonstrated or informed that the breakthrough results for empagliflozin confirmed that EMPEROR preserved, the other study with the same drug, as first and only successful trial for heart failure with preserved ejection fraction. And this is a very important issue in the subject that we are discussing now. Now, in third position, I wish to make some comments about how do they work. Nowadays, nobody will accept that only the blockade in the renal tubulus, the receptors, the transporters of sodium glucose may explain all the results that we are observing and receiving with this group of drugs. I think that there are some of these potential mechanisms that are very consistent in different investigations, and one of them is that the diuretic effect of these inhibitors may differentially regulate the interstitial versus intravascular compartment when compared with loop diuretics. And it has important impact in the hemodynamic of the cardiovascular system and also at the renal level. But in the long list of potential mechanisms, there are a lot of issues that may mixture metabolic and hemodynamic effects, trying to explain that this group of drugs has a real cardiovascular and renal protection. In this very difficult slide, we can understand that this is a real long list of selected mechanisms associated with cardiovascular and kidney protection with this group of drugs. You may see in the red arrows that this list includes metabolic, oxygen consumption, anti-inflammatory and antifibrotic effects, action about the glomerular pressure, the preserved kidney perfusion, hemodynamic actions in the cardiovascular system, and including many other management or impact in some key parameters like sodium, oxygen use, etc. This long list of actions are now related, many of them, to the role of the sodium hydrogen exchanger, which type 1 is located mainly in the cardiovascular system, and when they are activated through different mechanisms that I have mentioned, may produce progression in heart failure and in heart damage. The other exchanger, the number 3, is mainly located in the kidney, and also through different mechanisms may produce some progression of diabetes and renal dysfunction. What is interesting that there are some papers demonstrated that the key neurohormones of the renin-angiotensin system may interact with the sodium exchanger, sodium hydrogen exchanger, when both systems are hyperactivated. And it may explain the effect of the new group of drugs that we received from the diabetes world. The GLP-1 agonists and the PP4 inhibitors that are being also studied in the cardiovascular system may produce mainly inhibition of the type 3 exchanger, producing some benefits in the diabetics and renal function. But the gliflozins produce the inhibition of both exchangers, and therefore, in addition to the previous benefit, they may also produce reduction in the risk of major adverse, I would say, cardiovascular and not only heart failure outcomes. And according to the previous slide, we can understand that the inhibition of the renin-angiotensin system may produce an additional benefit in the action of the gliflozin, and we can postulate the possibility of using both groups of drugs together. And in the final part of my presentation, I wish to justify why we consider that this group of drugs is becoming a real blockbuster. If we add to the previous evidence the evolution of the group of drugs in heart failure management, as it was published by Bramwell and Cox a couple of years ago, they were studying the preclinical or subclinical stage of the disease with many trials, all with positive results. Then other studies demonstrate that the benefits in the clinical stage, and then a detectable cardiac, I would say, renal involvement is demonstrated now. But what is very interesting, and probably a key issue in this field, is the consistent evidence of a potent anti-inflammatory effect of the inhibition of SGLT receptor. It has some influence in the reduction in oxidative stress, the stimulating anti-inflammatory macrophages, the reduction also of the same things at the renal system, and even a potential reduction in atherosclerotic lesion progression. Just a couple of papers demonstrating this important mechanism of action. In this case, with empagliflozin, that the renal benefits has been primarily attributed to metabolic and hemodynamic drug effects, as we said previously, and the direct antifibrotic mechanisms have also been demonstrated, and this is very important. And the other article that is an example of this important mechanism of action is with dapagliflozin inhibiting the progression of left ventricular mass when it is with some hypertrophy. But another clear demonstration of the importance of this anti-inflammatory effect is these trials presented and published that is an excellent idea of Mikhail Kosiboro, who directed the study, and we, as I said, presented recently in the ACC. The DARK-19 trial demonstrated a benefit that didn't reach the ideal P value, but a consistent benefit of in the prevention of primary outcome in patients with COVID hospitalized compared with placebo. And also the safety endpoints were better demonstrated in the group of patients receiving dapagliflozin. As you may understand, this is important because it opens the door to the possibility of the use of this drug in other inflammatory diseases. And finally, just a comment about the expanded spectrum of SGLT2 inhibitor actions. We have confirmed the benefit in diabetes, reduced ejection fraction, and CKD, but with the recent results of Emperor preserved ejection fraction should be moved to the confirmed demonstration. They are also being explored in acute heart failure, post-MI, and COVID, as I said. And there are other additional opportunities in other disease and patient populations. But let me show one extra slide about the confirmed benefit in reduced ejection fraction. Compared with the conventional management that we have been using recently, a group of key opinion leaders have proposed a different management, including the gliflozins and the beta blockers in the first line of drugs, then the interventions of the renin-angiotensin system, and then the MRA in only 4 weeks. This is a new concept that I am absolutely sure that will be included in the next edition of international guidelines. In conclusion, first, in several large trials, SGLT2 inhibitors have prevented heart failure or have prevented or demonstrated lower cardiovascular outcomes in diabetic patients. Second, some trials showed similar effect in general population. Third, there is growing evidence that some new mechanisms of action can produce clear benefits in cardiovascular and renal protection, mainly through the inhibition of inflammation and fibrosis. And four, ongoing large trials will demonstrate if the above facts become this group of drugs in a new therapeutic tool for heart failure, CKD, and some other inflammatory disease. And with these beautiful pictures of the nice city of Singapore, many thanks.
Thank you, Prof. Martinez, for the speech. So now we'll move into our Q&A session. So today we are very privileged to have Prof. David Sim as well as Prof. Suwanto live to answer all the questions that you have. So just another call, if you do have any more questions that you have for the session, please feel free to type into the live Q&A box and we'll try to answer it during this session. So for the first question, we have a question on IV iron. I think I'll direct the question to Dr. David Sim. So this question is on the patient profile that iron should be taken in. So is there any requirements about the symptoms of the EF value for patients with heart failure, which the iron profile should be taken? And when should this iron profile actually be taken?
Okay, so the iron profile can be taken either in an inpatient or the outpatient setting, and the ejection fraction has to be less than 50%. In those patients with preserved ejection fraction, the EF of more than 50%, we currently don't have any evidence yet, this ongoing study. So only limited to less than 50%, then we will give the option of intravenous iron. I personally would do iron profile for all patients who are admitted for heart failure, because the AFFIRMed HFrEF show that this group of patients, by giving iron early, we can prevent readmission. But for those patients that are seen in the outpatient setting, you can also do an iron profile. And if the ferritin is low, less than 100 or between 100 to 300, with a transferring saturation of less than 20%, we can also give the intravenous iron in the outpatient setting. It is a very easy way of giving iron. You don't need 1 hour infusion. Just a quick 10 to 15-minute infusion will do. And the risk of anaphylactic shock with ferric carboxy maltose, this formulation is very, very low. So far in the patient that we're given in National Heart Center Singapore, we're given so many patients, we have not seen a single case of anaphylactic shock with this formulation of intravenous iron. So do take note, you still need to give it only to those patients ejection fraction who are impaired, that's less than 50%. Above 50%, we will have to wait for the result from the ongoing trial at the moment.
Thank you, Prof David Sim, for the taking the question. So I think someone also have another question about the iron profile, about whether there is, how soon do we actually need to achieve this target serum ferritin levels in patients with chronic HF, or is there actually a timeline or a target that we need to hit for these patients that are on IV iron?
There is no target to say you must reach a ferritin within 1 week, 1 month. Usually what we do is, depending on the weight and the hemoglobin of patient, we'll give a dose of between 500 or 1,000 milligram. One dose usually can last a patient for a few months. So what we do usually is, after 1 dose, you can actually recheck it in about half a year's time. And if the iron level is still, ferritin is still low, you can give a top-up dose. There's no real need to say you must bring the patient back in 1 or 2 weeks to recheck the ferritin. And in the study that AFFIRMed HFrEF, we're seeing that the majority of patients throughout the 1 year duration actually only need 1 to 2 doses. So 1 dose, like what I say, usually will last a patient up to 6 months. And there's also a danger if you keep on giving iron, repeatedly over a few weeks, you may cause iron overload. So by taking this cautious approach, I think most of the time, we can get away with just 1 to 2 doses on an annual basis. Yep. And I think I just saw a pop-up question on, is there a difference between different kind of iron? So far, all the evidence for the intravenous iron for heart failure has come from ferric carboxy maltose. So if you want to be evidence-based, I will go with ferric carboxy maltose. And also this formulation iron is much more so-called less, much less allergic reaction than earlier version of iron such as Venofer or that kind of iron. So if you want to strictly go by guideline and the clinical trial, definitely ferric carboxy maltose.
Okay, thank you for taking the question. I think this also leads us to this other question. I think you did present this during your talk, that actually oral iron is not really proven in patients' iron deficiency and heart failure. But in any case, in any setting, if the IV iron outpatient is not available and there's no such facilities to be administered, would you also recommend oral iron for patients with iron deficiency heart failure?
No, for 2 reasons. One, we know that the result from iron out heart failure show that it does not improve the symptom of patient, no impact on the exercise capacity. And second thing is also oral iron, despite not having benefit, it actually causes a lot of side effect, actually GI side effect, such as constipation. So if something is not going to help patient and yet you're going to give side effect, why bother to give it?
Okay, thank you for the question. So now we'll move on to the next question that we have on ARNI and HFpEF. So I think during your presentation, I think I will direct this question to Prof Siswanto. When you presented on the trial on ARNI and HFpEF, there is a subgroup benefit that is seen in women and also patients which are in the mid-range heart failure, but not in those that is EF more than 57%. So in your opinion, would you recommend the use of ARNIs in this case for patients with HFpEF that are within the mid-range region, or if let's say you have a patient who is a woman with HFpEF, would you preferentially start her on ARNI? Prof Suwanto, I think you need to unmute the microphone.
Thank you very much. So answering ARNI for the patient with mild range ejection fraction or moderate decreased ejection fraction is beneficial. We are not using ARNI for heart failure preserved ejection fraction that if the ejection fraction much more than 57, for example, much more than 63%. Then we don't use ARNI. However, when we look to on the daily practice, we use mostly in patients with ejection fraction less than 57%.
So in the women population, would you recommend them to be started on ARNI if they have HFpEF?
Yeah, women with HFpEF is more beneficial than men. So we will recommend, so from the Paragon trial, it showed that the most benefit is more in women and mostly the benefit of ARNI in patients with ejection fraction less than 57%. That's my answer.
Okay, thank you, Prof.
Sorry, maybe I'll chip in here because I took part in the Paragon HF trial. I led Singapore.
Okay.
So I have some insight into this. I think I saw a question on somebody asking as well, will we use the ARNI as a first-line antihypertensive in somebody who HFpEF? I will probably say no. First, we have to understand that the Paragon HF trial, no matter what we say, the subgroup analysis, we have to remember it is a neutral trial. If I'm kind, I call it a neutral trial. I'm not so kind, I will call it a negative trial. The p-value is not hit, full stop. When your p-value is not hit, you can do all the subgroup analysis, but I think it's very dangerous. Subgroup analysis is at most exploratory. And yes, we do see in the subgroup analysis, women tend to seems to have some benefit, and the ejection fraction of less than 57% also seems to have some benefit. I personally think that this group of drug can be used in patients with mildly reduced or reduced ejection fraction less than 50%. But once you go into a range of truly preserved ejection fraction of 50-something, personal experience that I'm using, I just tried a few patients, has not been very encouraging. So I would so-called look out for the upcoming Emperor Preserve result, as we have now the top line result showing that it is a positive trial. I can't reveal too much, but I am one of the co-author for this upcoming Emperor Preserve. Look out for the result, and we are quite encouraged by the strong signal that we see in the Emperor Preserve. So for now, I think I'm not so sure myself. The role of ARNI in HFpEF, I think, will be quite limited.
Yeah, I think this was also mentioned in Prof. Martinez' presentation on the Emperor Preserve trial. That is the latest headline now that the results just actually showed some evidence, and one of the few HFpEF trials that actually showed some evidence in SGLT2s. So on that, maybe you all like to elaborate more if the use of, how would you all actually decide on the use of SGLT2 and Entresto for your patient? I mean, as Prof. David Sim said, usually he would not start start Entresto for HFpEF. But if it's for HFrEF patients, if they have to start on Entresto and SGLT2 and all these IV outpatient therapy, all this will actually add up to the bill cost of the patient. So then how would you all decide like which will be the priority for the patient that you'll use this all these different pharmacotherapy?
So if you look at the Canadian guideline, they have actually put 4 pillars of first-line drug for heart failure with reduced ejection fraction: ARNI, beta blocker, SGLT2 inhibitor, and lastly, MRA, that's spironolactone. These 4 are put as a first line. In the American guideline also, they put down that ARNI preferred over ACE inhibitor. So if cost is not an issue, these 4 drugs I think should be started for the patient. But if cost is an issue, obviously ARNI will have a bit of disadvantage. So how I choose eventually the drug for the patient will depend also on the profile of the patient. If blood pressure is an issue, as we know, ARNI causes a lot of hypotension, then I think drugs like SGLT2 and MRA will have advantage. Hyperkalemia, renal impairment is an issue. ARNI and MRA will be an issue as well. Whereas if a patient has renal impairment, SGLT2 will be an ideal drug because we know that now SGLT2 has been approved for CKD management as well. So it really depends on the profile of patient. Whereas a patient who have a lot of issue with high blood pressure, I think ARNI will be an ideal so-called candidate. So I don't think there's a one-size-fits-all. The guideline is there, but you need to look at the patient as a whole. But in the ideal world, you will want all these 4 drugs. As you know, heart failure, there are a lot of mechanism is affected. So you want a bit of everything to target the different aspect of heart failure. I think the old concept of start first line drug, it doesn't work, you go on a second line followed by a third line, that concept has been now in a sense outdated. I think the new concept in the future will be right from the start, you whack all the different mechanism, a bit of everything, and they up titrate gradually.
Thanks, Prof. Thank you, Prof. David Sim. I think with all the guidelines recommending all these different pharmacotherapy, there's always the issue of polypharmacy in patients, and some patients are not willing to start so many medicines at the same time also. So I guess we really have to tailor the pharmacotherapy according to our patient profile as well. So on top of that, there's another question also on the use of SGLT2 inhibitors and also on the risk of diabetic ketoacidosis. So I think in one of the trials that was mentioned, the soloist WHF trial, they did start it for patients with worsening with an acute heart failure episode. So I think in line with this and with how would you say is the risk of diabetic ketoacidosis with the use of SGLT2 inhibitors? And have you seen any in patients in your setting, whether they are more prevalent in patients with diabetes or patients with HF but without diabetes?
So you have to understand that soloist is not a pure SGLT2. They're looking at sotagliflozin. It is a combination of SGLT2 and SGLT1 inhibitor. So because of that, there was some concern with the DKA. Whereas the SGLT2 in the heart failure trial, even regardless of diabetes or no diabetes, whether it's in the Emperor reduced trial or in the DAPA-HF, looking at 2 different kinds of SGLT2, namely empagliflozin and dapagliflozin, the incidence of diabetic ketoacidosis is very, very low. And in real life, we also don't see a lot of diabetic ketoacidosis if you take certain precaution. So if a patient is feeling unwell, not eating well, or going to have a procedure that you need fasting, that group of patient, I would suspend the SGLT2 during that period. Only when they start eating again, they're feeling much better, then we can restart the SGLT2 inhibitor. Just stopping the SGLT2 during this critical ill period, when they're starving, starvation, it's not going to make a big impact on the overall management of heart failure. So overall, I would still say it's very safe. You just need to take note of all this stressful period when they're being so-called undergoing starvation.
Going along with that, actually, I would also like to ask if there's any time period, let's say after an acute heart failure episode, where patients are on IV diuresis and then they achieve their dry weight, how soon will you actually start the SGLT2 after that episode of heart failure?
The current trial is all done in the outpatient setting. So DAPA, HF, and EMPA reduce. There are two ongoing trials now, both with DAPA and EMPA, looking at acute heart failure patient to start during inpatient setting. Two very small trials, a few hundred patients. Results should be out soon. But personal experience, I do start a lot of patients at SGLT2 during inpatient period. The rationale for it is just like ACE inhibitor, beta blocker, all the trial was done initially in the outpatient setting, but as we get more comfortable, more experienced with the drug, I think most of us are comfortable starting in inpatient setting. And it makes sense to start during inpatient setting as well, because the patient are most vulnerable to cardiovascular mortality and readmission in the post-immediate discharge period. So if you were to start the patient weeks after you see them in the outpatient clinic, you may miss this golden period to so-called prevent the cardiovascular event. So personally, after the first 48 hours, if the patient are well, they're eating okay, no acute kidney injury, I'm comfortable to start just before discharge.
So well, from what Prof David Sim said, it seems like the acute heart failure stage when patients just get admitted is really the golden opportunity for us to initiate all these guidelines-directed medical therapy and to slowly start these patients on it and up-titrate outpatient. So we have some other questions on the ARNI use, which I will direct to Prof Siswanto. There are a few questions on ARNI use and how do you initiate ARNI in heart failure patients? Do you prefer to initiate them in the acute or in the outpatient setting? And what is the washout period of transitioning between existing ACE or ARBs to ARNI?
Thank you very much. For in the acute setting, there is a trial, we call it a pioneer study, where it can be used ARNI in the acute setting, of course, with very caution. And the other thing is how to change from ACE to ARNI. You should stop the ARNI for 24 hours or 36 hours before initiating the ARNI. If you change from ARB to, for example, valsartan to sacubitril valsartan, the washout period is more less. So I mean, you should be aware when using ARNI. You should watch out for the hypotension effect and to avoid the effect of the previous medication like ACE inhibitor especially. That's my comment.
If I can add to Bambang comment, for those of you who are interested, you can refer to the publication in 2018, the Pioneer HF that was published in New England. There was a study of about 800 over patients recruited in USA in the usage of ARNI in the setting of acute heart failure. So in general, it's very safe, but just make sure your patient is not on any inotrope for the last 24 hours, not on intravenous diuretic for the last 6 hours. I think if you do that, it's quite safe to start ARNI. True hypotension is still an issue, so I will start a small dose rather than you're not going to go 100 or 200 milligram. Start with a small dose of 20, 50 milligram for this group patient. You usually can get away with it.
Thank you, Prof David Sim and Prof Suwanto. I think we do see in practice that actually ARNI has a much greater BP lowering effect than ACE or even ARBs. So with regards to the washout period, I think I also observe some doctors will actually, for patients that are pre-existing on ACE inhibitors, they'll switch them to an ARB first because it doesn't really need a washout period, especially if they do have uncontrolled hypertension that they would really need an ACE or ARB cover. So let's say switch to a valsartan, and then after that they will start on Entresto. So for patients who are on ARBs, usually there isn't any washout period because I mean valsartan is also in Entresto. So some patients, if they are aiming to actually start Entresto for this patient as the end goal, they will actually start them on valsartan initially if they can be compliant and their blood pressure can tolerate. Then we'll ultimately switch them to a ARNI. Yeah, but if any patients on pre-existing ACE, because of the risk of angioedema, we do recommend a 36-hour spacing before switching to ARNI.
Yes, thank you.
Okay, and We also have another question which regards to IV iron therapy. So this question actually asks on whether serum ferritin, which is also one of the inflammatory markers, can be reliably used to determine iron deficiency in patients, in heart failure patients with coexisting inflammatory conditions.
Okay, so yes, we do know that the inflammatory process can result in an increased ferritin because ferritin is acute phase reactant. So in fact, heart failure itself is some people believe is a chronic inflammatory process. So in the setting of heart failure, if we were to diagnose somebody with iron deficiency, that ferritin is low, then you know this is very, very true. But in somebody, for example, having acute sepsis, that the inflammatory marker is high, such a ferritin, then can you trust, is this really high because of sepsis? Or when the sepsis settle down, then the ferritin may be much lower. So what I will do is, if the ferritin is low, you can trust it. If it's high and the patient is having acute inflammatory process, what I will do is, I will wait for the inflammatory process to settle down, and at a later date, recheck the ferritin. It is low, then I will say that this patient will probably need iron replacement as well. Anyway, just to take note, when a patient is having acute sepsis, acute inflammatory process, we are not advised to give ferritin, to give intravenous iron at that point of time, because in patients with bacteremia, with acute sepsis, iron is contraindicated because iron is actually what the bacteria will thrive on. So you may actually worsen the septic process.
So just to summarize, so I mean for patients with sepsis, I mean since we won't actually envision to give them IV iron soon because actually we don't use it in patients with acute infection that are on antibiotics, we would prefer to take the iron panel when their inflammatory condition has settled and they are more stabilized so that we can get a more accurate representation of the ferritin, and also from there we can actually give them the IV iron. So the next question would actually be on what are some of your thoughts with regards to the effectiveness between SGLT2 or GLP-1 agonists to decrease the risk of cardiovascular disease?
So I think quick answer is both SGLT2 inhibitor and GLP-1 in the setting of diabetes, we know that they reduce cardiovascular event, but particularly for the heart failure event and CKD event, that is specific to SGLT2 inhibitor only. And we know that GLP-1 is mainly used in diabetic patient, whereas SGLT2 now we also have data to go beyond diabetic patient in non-diabetic CKD patient and non-diabetic heart failure patient as well.
Okay, thank you, Prof. David Sim. There's also another question on SGLT2 and how long should it be withheld prior to angiogram or any contrasted scan, on whether it should even be withheld before these scans? And if yes, how long would it be to withheld?
I think there's no clear-cut answer here. It's very much to the individual institution. I would personally say that going for a big surgery, like a bypass surgery, for example, I would so say that reheld it 48 hours before. And for minor procedure like angiogram, I would say that you can withdraw, you can reheld it on the day itself. Like I say, these drugs are meant for chronic use. We're not going to say lose the effect of the drug just because I stop it for a few days. So it's really up to the different institution, but I would propose major surgery, 48 hours, minor kind of angiogram kind of procedure, maybe on the day itself, you just reheld it. Yeah.
How about Prof. Suwanto? Do you have any experience in your hospital or in practice? And how do they actually practice it in Indonesia? Do they withhold it prior to scans, like contrasted scan angiogram, or only before major surgery, such as what Prof. David Sim has said?
Yes, we about ARNI in angiogram, we just postpone just the day of the angiogram. We are more afraid about using metformin before angiogram. So mostly we just stop the ARNI on the day of angiogram. For the cabbage or big operation, we hold before the surgery. like 24 hours before.
Just to clarify, you mean for SGLT2 or was that for ARNI? To withhold 24 hours before the surgery?
The question is about SGLT2. Is before surgery, we stop just 24 hours before the surgery. Also for the angiogram, it's only for the day of the procedure angiogram.
I think Bambang mean Prof Bambang means SGLT2 inhibitor. I think it was slip of tongue.
Yeah.
Okay, just needed to clarify for the audience. I think there is also another question on actually the provision of SGLT2 inhibitors that is recommended to non-diabetic patients with the hope of reducing the severity of heart failure. I think we can go along the lines of whether you do see any difference in terms of patient adverse risk profile or adverse reaction when you do give SGLT2 to patients with diabetes and SGLT2 with patients without diabetes. Do you feel like patients with diabetes actually tolerate the SGLT2 better with lesser side effects?
This all has been answered in the two big clinical trial, AMPER Reduce and the DAPA-HF. When they look at a different subgroup, the benefit was equal across the whole spectrum of HbA1c, from normal HbA1c to elevated HbA1c. In terms of efficacy, it's the same as well. And in terms of safety profile, again, we don't see a difference between a diabetic and a non-diabetic patient. And I can reassure that the patient without diabetes, I'm sure some will be very, very so-called cautious about would it cause hypoglycemia in somebody without diabetes. I'm giving a diabetic drug. No. Answer is in this group of patients, we don't see an increase in hypoglycemia.
I think that's very reassuring for people to start patients that, a known diabetic drug for patients without diabetes, and also patients as well, if they start to Google and everything and then they see it's a diabetes drug, they also wonder like why they are on this. So I think the next question, I can direct it to Prof Suwanto. So with regards to the trial on ARNI, as Prof David Sim said, their major outcomes actually didn't hit statistical significance. Do you foresee any future use and use of ARNI in HFpEF, and whether there are any future trials that would actually prove any benefit of ARNI in HFpEF patients?
Thank you very much for the question. Also to Dr. David Sim. I prepared my slide before the SGLT2 results published. So I mean that for ARNI, we still hope it can work. It can together useful, especially in patients with reduced ejection fraction. And now coming the Emperor Preserve that give a better result for preserved ejection fraction. So also already mentioned by Prof Felipe Martinez. So in the future, maybe SGLT2 is better for preserved ejection fraction rather than ARNI in preserved ejection fraction. Yeah. However, already launching many long time ago with Dr. Sim in Jakarta using ARNI. So many of doctors already using ARNI before this. And now coming the SGLT2 and it give a good result in heart failure with preserved ejection fraction. That's my answer.
I don't think we will ever see another HFpEF trial with ARNI again. Even if they want to do a new trial ARNI HFpEF, they will have to make sure everybody is on SGLT2 inhibitor.
Yes, yes, I agree with you. Okay.
It's just not possible. I don't think Novartis will be starting another HFpEF trial.
Yeah.
So likely HFpEF, the next upcoming blockbuster drug that we'll probably have to look into the class of the SGLT2 to see if there's any future benefits and reduction in cardiovascular outcomes. There's one question on actually COVID-19. So this person asked that we have seen publications with regards to COVID-19 related ACS or cardiovascular events. In your experiences, have you seen long-standing heart failure related post-COVID, and will ARNI be promising in this category of patients?
Yes, thank you very much. Very difficult to answer because we are still, I use my other mobile phone for the managing the patient with COVID. I don't have, it's difficult answer for me. I mean, COVID is really, really difficult for me, especially. So even the patient on SGL2 on ARNI, we have a difficulty to manage this COVID. That's my personal experience now.
Prof David Sim, any experience on your end?
Fortunately, not a lot, which is good. But I think if a patient has a heart failure and also had a previous history of COVID-19 infection, and the patient recovered from a COVID-19 infection, I think the treatment of heart failure should not be the different from any other heart failure patient. Depending on the ejection fraction, you still have to treat them with the appropriate drug. So in this case, if the patient has a history of let's say have a persistently low ejection fraction, ARNI will definitely be appropriate.
Okay, thank you, Prof David Sim. I think we'll just take one last question before we wrap up this session. So the last question actually is quite an interesting one. So I think this person is asking of whether do you think there's any role of linagliptin in HFpEF?
It's a almost impossible question to answer. I'm not sure why suddenly this pop up this linagliptin in HFpEF. The only way to answer this question is to do a clinical trial, and I'm not sure. But of course, we must have some so-called rationale for doing a big trial. So I think what prompted us to use SGLT2 inhibitor to test out in HFrEF and HFpEF was because of very strong signal that we see in a diabetic patient, the non-heart failure trial in diabetic patient. When we use the SGLT2 as a diabetic drug, there was a surprising result and finding of benefit of reducing heart failure, unexpected finding. But I think in the clinical trial involving linagliptin in diabetic patient, that signal was not there. It was neutral. In fact, if you look at the DPP4 inhibitor, depending on which DPP4 inhibitor, some of them actually can be harmful. For example, saxagliptin was associated with increased use of heart failure. That's why we don't use it if we are afraid of heart failure or in heart failure patient. In linagliptin, fortunately, it was a neutral effect, but we did not see in a diabetic patient a reduction in heart failure incident. So if we don't see a signal there, I think it's hard to postulate that it may work. I don't think there will be any clinical trial, randomized clinical trial to be done in it. So I think that question will probably never be answered. The likely answer is probably it will not work, but I can't be certain until we're clinical trial, which I think will never happen.
Okay, thank you to both speakers, Prof David Sim and Prof Suwanto, for actually taking the time out of your schedule to join us in this live Q&A session. So with this, we will actually round off the first session on heart failure, and we hope that you have actually managed to learn something and gain some insights on the latest heart failure pharmacotherapy. And we look forward to you joining us in all the other sessions and having a fulfilling 2 days at this virtual congress. Thank you.
Thank you.